Well, let's now turn to the challenges to implementation of newer and better treatments and the ambitions for future patient care. I'd like to start with you, if I may, Professor De Corso. I mean, clearly we've talked there about having the right patient, making sure that we get the right patient, that they then are given the biologics. For you, what are the current obstacles for using these biologics in clinical practice?
One obstacle is surely the cost, and we spoke about that. So I will speak about another problem, because I think that another crucial point is the definition of severity and of control of the disease. I think that international and national guidelines and position papers have been helpful in establishing specific cutoffs to measure severity of disease. It is obvious that if a patient may reach an adequate control of symptoms for many years with just one surgery plus intranasal corticosteroids, in this situation, surgery is surely more convenient than biologics. On the other hand, there are patients who will never reach appropriate control of symptoms even after undergoing surgery and cycles of systemic corticosteroids. In these patients, biologics, although more expensive, may dramatically improve patient quality of life. So we need to be more restrictive in order to give priority to severe patients. I personally think that now it makes no sense to repeat surgery, thereby increasing the risk of severe complication without reaching adequate control of the disease. And another obstacle may be the safety, but it doesn't appear to be an obstacle, because the experience in the trials and in real life confirmed that these are very well tolerated drugs with a very low rate of serious adverse events. Some are afraid about long-term adverse events or about the risk of loss of efficacy over the years. But currently we are missing data, but we will know more in the near future, I believe. And the last point is the patient perspective. Some patients are either not adherent to chronic therapy or point blankly refuse long-term, long-life therapy. They may be influenced by wrong information or by social media. And for this reason, education is essential, and EUFOREA has demonstrated over the years the importance of ensuring clinicians are updated and well informed.
I mean, it's really interesting, actually. You talk about safety and efficacy. That was going through my mind. Professor Fockens, can I bring you in here? I mean, clearly we've talked about cost benefit. We've talked about safety and efficacy. We've talked about longer term treatments. And obviously, patients have to be willing to go on these drugs, don't they?
Definitely. And of course, we have one biological that is already on the market for 20 years for asthma, not for polyps, but at least we have the safety data that is absolutely safe. But the other biologics are available only for a few years. And although we do not have any indication at this moment that they're not safe, and they're definitely much more safe than the systemic corticosteroids that we had to give to patients before, we of course need longer periods of time before we can say that. And for example, at this moment, I do not want to give the new biologics to patients who want to become pregnant or are pregnant. On the other hand, one of the important things we already mentioned, cost, but of course there it's very important how often do we need a biological. And now we do not have data to significantly reduce the number of injections per year. But it's very well possible that we will be able to keep the patient well controlled with far less medication per year. And that might be one of the solutions to reduce costs for the community or for the individual patient.
Well, let me just bring Alexandra back in now, because I mean, I was really struck by you saying it didn't matter whether it took 10 years off your life, because obviously the improvement was so significant. Were you ever worried about the safety of these drugs?
Of course. One of our youngest daughters, she is having the same symptoms as I do have now. She's 26, and as Dr. Fokken says, with pregnancy, I wonder if I want to join her to hospital to see if this is the only solution. Because, for me, and this is also a question I have, I am almost nearing my 60s. Is there a certain age that the illness without any medicine will be controlled due to, sometimes you read on internet that if people have a certain age, this polyps may be gone without any treatment.
Yeah, I mean, let me bring in Professor Mullall then, just in terms of the length of treatment here. Just from, is there anything you want to add here in terms of talking to patients about safety, efficacy, duration of treatment, how long they have to be on these?
Of course. The duration of treatment is something that we don't know. The experience with asthma or severe asthma, there's the potential equivalent to that is patients are treated for 3, 4, 5. Most of our severe asthma patients are treated for more than 6 years. Some of them, the others can be tapered down, as Professor Fokken said, that this is a reaching possibility. About safety, I totally agree with her. That means we don't have any notice in the new biologicals that a high number of patients or a significant number of patients could have strong side effects. I remember one patient that in the clinical trial have a local erythema, and that was growing injection after injection, and we had to withdraw from the study, and she was crying, and as it has been said before, she said that she preferred the risk of having an adverse effect such as anaphylaxis than being removed from the clinical trial because she felt so. That is the magnitude that these patients can be linked to this treatment that is, for most of them, very beneficial.
I mean, that's beautifully illustrated there. Thank you very much indeed. Professor Han, I mean, clearly cost is going to be an issue. Healthcare is very, very expensive, increasingly expensive. How do we get industry to pull down the costs of these drugs? I mean, is it partly that it's going to be a passage of time? It's obviously as they come off patent, but also is it the more patients that are on them, we can drive down cost? Is there something that we can do?
I don't know the answer to that. I think it's going to have to be multiple factors that have to be involved, whether it be the pharmaceutical companies, the distributors of these medications, or even the governments, the national governments themselves, developing restrictions on how much to charge for these medications. As you heard, these are game-changing medications for patients who have a severe disease with severe quality of life. The cost of these medications is a burden, and I think regardless of where you live, it is an international issue. I will say that one thing that we have noticed over time with use of a lot of these biologics for nasal polyps is that, before COVID, most of the patients who were getting biologics were coming into our office and getting it every 2 weeks or every 4 weeks, depending on the frequency in which these biologics were supposed to be given. And so they would come into our office, we would give it to them, and we can kind of regulate, how frequently we gave it. But then when COVID hit, a lot of these patients wanted to learn how to give these injections themselves. And a lot of these biologics are considered safe by a lot of these regulatory agencies to be given at home because the risk of anaphylaxis and such are pretty low. And so what we noticed over time is these patients who are administering the biologics themselves, what we noticed over time was that they would feel so good so that they would start increasing the length of time between injections. And they were still having pretty good results as long as they were on topical steroids. And so, I mean, that is another way of decreasing cost in a way, but I'm not sure if that is the right way to decrease cost.
Well, thank you very much indeed. That's a brilliant point there. And thank you to all of you about all those comments on the challenges we face and indeed the ambitions to improve patient care around the world. Very quickly, if I may, I want to just get your final thoughts. If you can encapsulate everything that we've been talking about today. If I may start with you, Alexandra. I mean, I think your story is remarkable. What is the final message you want to leave our viewing audience with?
I am very happy with the attention to this chronic disease because I think, you know, it's not that you're talking about having a cold. And, you know, if you have this disease, a lot of people think, oh, you're having a cold. But, you know, with what EUFOREA does with the things they publish is that more people know what is behind this illness.
Yeah, I know, brilliant. And Professor Mullol, your thoughts, how do you wrap up this conversation?
Well, only to say that severe patients with chronic rhinosinusitis with nasal polyps should talk with their doctors and realize together what is the better treatment. Not the solution is always in the side of biologicals, and treatment with surgery and the standard of care treatment also is very important before reaching this severity. I think that the conversation and the agreement and the final solution taken together between doctors and patients is the best to control this severe disease.
Professor Han, your final thoughts. What do you want to leave people who are watching this? What message do you want to leave them with?
So I'm very grateful that we have a new class of treatment options for our patients with severe nasal polyps. And if you look at the clinical studies looking at all the biologics for nasal polyps, they all worked, but it wasn't all 100%. So what would be great is if we can identify which biologic would really work well with specific type of nasal polyp patients so that we can get to that level of 100% efficacy to the point where every patient on a biologic gets that improvement. Right now, we don't have that information. We're still researching that. So we still have a little ways to go to get high efficacy results for all the biologics, but I think we're getting there. But we're just grateful that we do have this new treatment option.
Brilliant points. Dr. Eugenio De Corso, your final thoughts?
So I think it's very important to explain our patients what it is important to improve their quality of life, because sometimes they accept their condition and they don't understand that the condition can change because we have new opportunity for them. And I think also we have to educate our ENT colleagues, because it's very important to help them in understand the indication, to how to measure the disease, and also it's important to very well explain place in therapy and what is the target to treat of the patients. And finally, I think we have to enjoy with our patient the success of this drug.
Well, I couldn't agree more. Professor Witzke-Fockins, perhaps I could bring you in last, but by no means least here. I mean, really, we've heard some fascinating stories. We've heard how it's a game changer, how we have to have the right patient on the right medication. What are your final thoughts, and how do you view where we are and where we're going?
Well, thank you very much, Dr. Bull. I think this has been an excellent discussion on all the aspects of treating chronic rhinosinusitis with nasal polyps. Extremely important to understand the impact on quality of life, important that patients realize that they have a serious disease and that they are entitled to all the care that proper care that healthcare providers have to give them. And whether that is a local treatment, whether that is surgery, or in some patients eventually a biologic is needed, is at the moment a matter of discussion between the healthcare provider, the doctor, and the patient. And of course, that is shifting over time. 10 years ago, we didn't have biologicals for nasal polyps, and what will happen in 10 years, nobody knows. Whether chronic rhinosinusitis with nasal polyps will eventually be a curable disease with limited resources needed is not clear at the moment, but I hope that what we show today will give patients a lot of hope of what is possible in this terrible disease that they have at the moment.
I couldn't put it better myself. Thank you so much to all of you. Well, sadly, that's all we have time for. Many thanks indeed to my panel for their thoughts and comments. And it really has been a fascinating debate. And I really want to thank all of them for sharing their thoughts, their views and their aspirations. So many thanks to my guests, to Alexandra Banink, to Professor Joachim Mullol, Professor Joe Hahn, Dr. Eugenio De Corso and Professor Witzke Fockins. And thank you to all of you for watching this EUFOREA Innovation Forum debate on setting the new gold standard for CRSwNP treatment. And I really hope that you found it useful, informative, but most of all, it is really important that you take forward everything that you've learned and you implement it in your clinical practice. Now you can find more information about EUFOREA and also register for the EUFOREA meetings on the euphorea.eu website, where you can also sign up to receive the latest news via email. And don't forget to follow us on socials for all the latest news and information. But from all of us here, goodbye.